Good afternoon. It's Dr. Coleman at United Physicians. Thank you all for joining us. We're going to go ahead and get started. Just a couple of housekeeping issues. What we'll do with this, we'll go ahead and present some information. If you could keep your phones on mute. If it's on a speakerphone and it's not muted, we do get a lot of feedback and it interferes with other participants' ability to hear the program. We will pause periodically through the webinar to open it up for questions. The other option is if you are logged on, remotely through the web link, there's a chat option that you can submit questions as well, and we'll kind of monitor that as we go. Real briefly, I just wanted to introduce the individuals that I have with me today. Dr. Frank Satil, who has joined our medical management staff as a medical director. Lori Schultz, who has recently joined our medical management team in the area of clinical quality improvement, and also Jeff Burton, who is a member of our medical management team working in the same capacity. I believe Diane Swan may be joining us partway through. She works actually with the team that generates these reports and looks at the data and helps us kind of synthesize it and get it back out in a way that is helpful. So we'll go ahead and get started. What we're going to focus on today are there are four reports. They're the primary care Blue Cross physician trend report, the primary care managed care trend report, and then those same two reports for the specialist physician. With that said, we'll also be showing some of the supplemental information that if you do identify when you're looking at your reports an area of opportunity, we can provide some additional guidance and make it a little bit more actionable. So I'm going to pull up the first report, and this is an example of a primary care physician trend report. We run these reports on an ongoing basis, and one of the first questions that typically comes up when I'm talking with physicians is, why is this so far behind? This is a report that shows from January 2012 to March 31st, 2013. Part of that, about 6 months of that time delay, is related to claims run out, because these are based on claims data, and it does take a certain amount of time for that to get through the plan and then to get forwarded to us. There's another period of time that it takes on our end to get this processed in a format that can be represented back out. This particular report was delayed a bit longer in distribution because of some other Blue Cross reports that were being sent out to the offices, and we didn't really want to have them both out concurrently. So that's one of the first things. These really are intended to provide a real high-level look at where are your opportunities. So, for instance, when I look at this report, the generic use rate actually looks quite good. As you look at these on the Blue Cross, the data source is the Blue Cross Blue Shield of Michigan claims. One thing when we were looking at the Blue Cross data that is important to be aware of is that for generic use rate, this includes not only the primary care physician's prescriptions that they write for their attributed patients, but also any prescriptions written by any other provider for those patients. So Blue Cross is an attribution model. They link patients to you, even though they don't have to declare you as their, official plan PCP. They do have a model that kind of links a group of patients to you. All the prescriptions that are written on those patients are reflected in this. So in this case, the physician's generic use rate is 86%, and that's reported in green to indicate that it's favorable. The practice unit's at 83, which is slightly below the benchmark, and the benchmark is that black dashed line that's greater than 85%. I want to take a minute and talk about generic use rate. One of the things that we're seeing a shift, and Jeff, you can chime in, I think the plans are moving away from generic as a measure.
Yeah, I think that what the plans are seeing with their data is the generic use rate is kind of plateauing. Every different specialty has obviously different opportunities based on the drugs that you prescribe. However, their focus moving forward will be primarily on overall pharmacy costs, in particular some of the specialty drugs. So while we'll continue to monitor generic use rate because that definitely goes hand in hand with cost, we'll kind of think of it in the light of total pharmacy cost moving forward.
Okay, so one of the other things I'd like to draw your attention to is on the far right-hand side, the benchmarks. So for generic use rate, high-tech radiology, and ER utilization, these benchmarks that we're using in this report are based on the Noman moderately managed benchmark that's set for the Southeast Michigan region. I think it's important to point that out because this is it's an industry standard. It's not just UP comparing itself to UP or even UP comparing itself to Blue Cross. This is a standard that's used across a variety of different plans, and these are the benchmarks that we're being held to. So in terms of kind of moving through this report, the next area is high-tech radiology. And in the description of the measure, you'll see that this also includes studies that are ordered by primary care physicians and specialists on those attributed members, and includes the ER studies as well. In this case, the provider is quite a bit higher than the practice unit and the benchmark. And what we're going to do as we get closer to the end of the presentation, we'll talk a little bit about strategies. If we were approaching this and trying to help identify opportunities, what are some of the tools that we have here at UP to kind of help you out with that? ER utilization is the number of ER visits per 1,000 members. That's kind of a standard way of reporting that. And this is okay. It's above the benchmark. It's not horrifically above the benchmark. But it would be an area that if I were on the receiving end of this report, I'd want to kind of look at, are there reasons that my patients are seeking care in the ER at a little bit higher than the benchmark rate? Is it an access issue? Is it an education issue at the practice level? Blue Cross calculates a quality score, and that's the next measure. That's the fourth one down. And that is in the form of an evidence-based care report, or EBCT score. So one of the things, and this has to do with closing HEDIS gaps in care. So HEDIS the HEDIS measures are quality measures that, again, are standard across the industry. And I always goof this up when I try to say what HEDIS is. It's the health. Okay, feel free, anybody.
Health employer.
Health employer data.
Information system.
Yeah, okay. Health employer information. Data information set. But these are when you get those gap in care reports, it's what Blue Care Network's looking at, it's what HAP's looking at, priority. And then Blue Cross takes this and aggregates it into an evidence-based care score. So we look at that. It's going to reflect predominantly these quality measures. If that score is trending down, and the scale on this is really, I'm not sure that I'd even consider that a really big, if you look closely at this, which is probably hard to do, the difference in the scale runs from 75 to 79%, so it does go down. It's worth looking at that. High-tech radiology does factor into that, and looking at this, I would guess that the bump in ER and high-tech is what's driving that quality score down a bit. One of the things with regard to that quality score, for for patient-centered medical home designated practices, the weighting for, or the relative weight of your overall designation score is based in part on your quality scores and in part on your PCMH capabilities. One of the trends that we've noticed at UP is that over the past several years, offices have added a lot of capabilities and it's starting to level up. In fact, our average capabilities are 82 right now in the primary care practices. So it's not as big of a differentiating factor between one practice and another, and the quality scores I think are taking on a little bit more importance in that assessment.
Yeah, Kim, I just wanted to add something in regards to the PCMH designation. Not only is Blue Cross using the number of capabilities and the quality scores, but they're also using these other utilization scores, generic use, ER, and both high-tech and low-tech radiology. So all of those factor into PCMH designation score.
Okay. I'm going to just briefly open this up for questions on this initial report before we move on to the PCP managed care.
Kim, this is Wendy Chandler. Are these reports found on the UP portal?
They are. Are you asking with reference to the Beaumont Medical Group?
Yes. Are they? They are located on the Beaumont Physician Practice Unit folders on the UP portal. Is that correct?
Wendy, you know what? I guess I would need to check on that. I thought we transmitted these reports to you.
I have the specialty reports, Kim. I just wanted to let other people on the call know that I believe these are located for PCP trend reports in their practice unit folders. That's my understanding for the Beaumont Medical Group. We do mail these out directly to the independent practices because not all of our physicians have portal access. Okay, thank you for clarifying that.
Okay, thanks. Other questions? Okay, I'm going to move into the managed care report. Okay, so this is set up and he has the same categories with a couple changes. Generic use rate. In contrast to the Blue Cross report, the managed care generic use rate reflects only prescriptions that are written by the provider. They're linked to that provider's DEA number. So for instance, if you found that in the Blue Cross data set, your generic use rate was much, much lower than it is on managed care, that could be an indicator that some of the impact on your Blue Cross generic use rate is coming from specialist physicians that you're referring your patients to. One question that I get fairly often is why is there a difference between my generic use rate in HAP and BCN? That most likely has to do with benefit design. They have different formularies, different tiering for prescriptions and copays. So most physicians don't, at least when I talk to most physicians say, well, I don't really do anything differently for, I'm not thinking about this as a HAP, so I'm going to write this, and this is BCN, I'm going to write this. Most likely on the managed care side, it's going to reflect more their pharmacy benefits. Tech radiology, similar to the Blue Cross, this does include studies that are ordered by other providers on your members that have you selected as a PCP. ER utilization, we have the ER visits per 1,000 reported again. This is another big area that benefit design impacts, because if HAP has a $500 ED copay and Blue Cross Network has a $250 ED copay, depending on what what the benefits your patient population has that could impact that one way or the other. Performance index, this is based on a data analytic tool called ProfSoft. It's a measure of cost efficiency, and it takes the physician's cost compared to peer group average cost, and also adjusts for case mix index. So if you have more complex patients with multiple diagnoses, that will be reflected in this. And it's normalized to a value of 100% or 1. So if you're under 100%, that would imply that you're a little bit more cost effective or cost efficient than your peer group. And in this case, if it's internal medicine, that would be other internal physicians. If you're above 100, that's going to indicate that you're a little less cost efficient. Now, I always caution people when they look at this, because even though it is case mix adjusted, there can be differences in your practice that would impact this. So, let's say you're a primary care physician, but you have a larger number of geriatric patients. Maybe they're not necessarily, more complex, but you have a little bit different patient population. I know initially when EP was reporting this, when I started my practice, we had a lot of new babies. So the cost per episode was very, very high because they were all coming in for their well visits and getting lots of vaccinations. So my cost per visit was in the, hundreds of dollars more than my peer group, and that age mix changed it. So just to kind of give you an idea. Quality score, one thing I wanted to, so Blue Care Network and HAP report a quality score. And they track that. And this is very similar to that EBCR score on the Blue Cross data set. When you're looking at your report this time, you're going to see the same trend that is being demonstrated on the screen here, and that is a decline in the quality score. And the reason for that is we did change our methodology between the last reporting interval and this one. When we did that, we're actually reporting this on a prospective basis now, so that when you look from the first quarter to the second quarter, you should see that you're closing more gaps in care and that quality score is going up. And we felt that that was more of a real-time tracking for that. So again, I'm going to take a brief pause here and open this up for questions with respect to the managed care report. Okay, so either I'm doing a really good job explaining this. That's it. Or not. I've lost everybody. Okay. Next report is the Blue Cross Specialist Physician Trend Report. Now keep in mind, Blue Cross doesn't, when we report, one of the differences between reporting for the primary care physicians and the specialist physicians has to do with the patient attribution. So we can capture claims from Blue Cross on, on services that the specialist provides, prescriptions, things like that. But when you're looking at those patients aren't directly attributed to the specialist. So the things that we're measuring are a little bit different.
Oh, you know what?
Generic use rate is, for the specialist in Blue Cross, reflects only prescriptions that they have written themselves. This is an allergist, and we have looked at generic use rate by specialty, and you'll notice in comparison with that PCP report that I showed earlier, I don't know if I get the mouse here, but the specialty average is 54%, and that reflects the fact that there are less generic opportunities in that specialty area. With that said, this provider has, over the time frame, is really trending very nicely in a positive direction. My guess is Singular is helping that because during that time interval, it came off brand.
You can't. That's the only one.
We're getting a little bit of feedback if there's someone that doesn't have the phone muted. We track total prescription count. Again, this is more informational. It just lets you know in comparison with other members in your specialty whether you write more prescriptions or less. And there's not a good or a bad attached to that. It just gives you that basis of comparison. Jeff had mentioned average pharmacy cost, and this is an area that we feel we'd like all of our providers to be focused on moving forward. So this is the physician's total pharmacy cost divided by the number of the unique counts of patients. Likewise, informational item, average services. So, are you doing a lot more services than your peer group? In allergy, that might mean more allergy testing. It might mean more allergy injections. It could mean more frequent office visits. This is, something that if your cost was higher, you might want to look at that and see where a difference is. And then specialist visits. So that's number of unique patient visits at the non-PCP offices. Again, has to do with the frequency with which those patients are seeing specialists. I'm going to shift to the managed care. And we have pretty much the same metrics. We have generic use rate for both Blue Care Network and HAP, and both of those are trending up. That total prescription count, again, it's really more informational. Average pharmacy cost, so a little bit of a difference. And again, when I see this between Blue Care Network and HAP, I tend to attribute that more to plan and benefit design. Average medical cost, I think that's a helpful thing to keep an eye on. Increasingly, we're seeing a shift in focus toward sort of per member per month cost for care. So I don't know, Jeff, do you want to maybe speak to the specialist uplift just in general terms with respect to, kind of some of the things that they're looking at?
Yeah, so for the specialists on the phone, obviously Blue Cross has come out in the past couple of years with specialty uplifts, basically trying to mirror what they've done with the PCPs and the PCMH designation uplift. The one thing I will say related to this report, when Kim was talking about cost, is that for each specialty group, you have either a list of metrics or there's one metric that Blue Cross uses if they haven't come up with specialty-specific metrics yet, and that is overall cost of care. And they do measure that in per member per month. So basic point is that cost of care, the total cost of care for patients that you see, whether that be services done in your office or other services relating to that care the patient done by key care partners such as the hospital or the PCP or other specialists, is something that we're really trying to point attention to, because that's where we feel as a specialist we can impact the most, which would mean potentially more specialists getting the uplift.
Okay, great, thanks. So similar to the PCP reports, we are able to run performance index for the specialty providers. So in this particular instance, performance index of 89%, which is well below the 100 sort of benchmark there, that would imply that this provider's overall cost efficiency is favorable compared to the peer average, and that's even in the face of case mix index. It's a little bit more complex. and then we have that same metric, the specialty visit. So what I thought I would do, I'd like to show you, I'm going to go back to reports. This was the first report that we looked at for the primary care physician and the Blue Cross data. And while the generic use rate has trended up, that's great. High-tech radiology, so if I were focusing, like one-on-one with this provider and identifying where do you have the biggest opportunity to, impact your quality scores, your total cost of care, it would be in this high-tech radiology area. So our health economics and analytics team has helped us out in developing some drill down reports, and I'm going to show you an example of that. So this is a Blue Cross high-tech radiology detail report, and I have I've taken out the PHI. If this were your report, it would have the member's name, it would have the referring physician, so that you would know whether you were the one that had ordered the test or whether it was one of the specialists. And I think it's a nice place if you do find that your high-tech radiology is high, it gives you an idea. For instance, when I look at this list, very quickly I can see that, there are a couple of complicated oncology patients that, may be driving that because they're getting images repeatedly. Now, it does raise the question, though, of are they getting is it imaging being done at the appropriate interval? And I think that's something we need to look at more closely moving forward. But you can also see your patients who go to the ED with a headache and have a CAT scan. It's like that's just one up from the bottom. One other tool that we have available, if when you look at your report you find that your biggest problem is your generic use rate, we can get a GUR detail report, and that shows where your brand name prescriptions are falling. So in this instance, like Crestor, a total of 120 prescriptions, that's a fairly easy generic substitution. Singular too, written, again, now this is, I'm trying to think one that came off brand. We may be picking up branded prescriptions on Singular prior to it being available generically, but we have done pharmacy and radiology improvement webinars and intend to continue to periodically update you on what's coming off label. So, but I think this is a good place to look for where are those opportunities. If you're focusing on those couple prescriptions down at the bottom of the list, they're not going to have nearly the impact that Crestor would have, or Celebrex, or Cymbalta in this case. So those are a couple tools that we have available that we can share in instances where you specifically feel there's an area you want to work on. Before we break for questions, I have asked Lori Schultz to provide for us a demonstration. I'll have her come over and set this up. United Physicians has been partnering with Alterum Institute, and we have a CMMI grant for medical innovation, and have used that to develop a radiology clinical decision support tool. It is accessible two ways, and I'll have her, she can talk about it right now. We're accessing it through our portal, but this is intended to help you get to the right test for the right problem kind of right away. It's quick. She's going to do a real quick real-time demo. The other thing that it has built into it is a patient education component. So that, like, when you have that patient that comes in with a headache and they say, well, my neighbor had an MRI scan. She went to the neurologist and she got an MRI scan. I want an MRI scan because I have a headache too. You have some additional documentation that you can share with that patient about why maybe it is not necessary for her to have have an MRI scan for that headache. So I think Lori's set up. Finally, yep, thanks, Dr. Coleman. Wanted to show you really how easily this is accessible and how quickly it can be done. I am just going to do a demo today. I'm not really going to go through a full-on training. Those are available for your practice. Please just make sure you call UP and ask for Gail Hartledge. She will be more than happy to come out and provide a training one-on-one with your physicians and your staff so they all know how to use ImageSmart and help you implement this into your workflow. But really what we wanted to show you today was just how simple it is to incorporate that into your practice. Once you're into the United Physicians portal, you just go over to your tools area and you click on ImageSmart. It will open in a separate window for you. And ideally this is done with a patient in the room with you. And you just go ahead and enter the clinical presentation of the patient. When you are testing or training, practicing with the tool, we're just asking that you please click this box right here that says I am testing or training. That is not then recorded as a live patient that you would be tracking any information on. So we have a patient that has presented to us today, a 45-year-old male. This is the only patient information that's available that will be entered into ImageSmart. He is here because he hurt his back over the weekend, so we're going to go and look for a spine. He has a spine injury. We're looking to do an MRI of his spine, and it's actually his lower back. You have to click Continue. And again, it's just a very uncomplicated case, low back pain, radiculopathy. There's really no red flags. Hasn't been going on for very long. Go over to the indications page, and you can add in here that there is pain. You can be specific to the pain. It's been less than 6 weeks. Maybe some sciatica or radiculopathy is present. And what this does then is it comes up with an appropriateness rating of the test that you were just looking to run. Remember, we asked for an MRI of this 45-year-old male. It came up with an appropriateness rating of nothing for MRIs. CTs would be, the closest would be a 2, which is very low on the appropriateness scale. We're looking for something 6 or above. But alternate care, if anything is below a 5 for appropriateness rating, alternate care comes up to the top. You can select alternate care. We know that at this point that we're asking that this patient have some physical therapy. We're looking for them to have at least conservative therapy, some pain management, and that sort of thing directly by the physician. And again, no red flag symptoms were present. There's a list here. And then what you can do with this patient, with this information, is you can print out a summary that can be given to that patient. It comes out in a PDF. And this can be given to the patient, and then it can also be scanned into their chart so that when they do come back after 6 weeks, if they still are having issues, you can go back and refer to this, that an MRI was not indicated at the time. Perhaps in the next 6 weeks it might be. Also what is available, which is very helpful, are patient education materials are also listed right specific to the body area that was mentioned in the clinical presentation, and that opens and can be printed out as well. 2 pages, it's excellent patient education materials. We've had feedback regarding this over the course of about almost a year now that we've had this available. I'm not sure if you were able to see all of that though because of the sharing mechanism that we have for our webinar. Again, you can access ImageSmart through the portal as long as you have UP portal access. If you do not have that at this time, you can go ahead and call the help desk at UP. They can have that assigned to you, and somebody can come out and train you real briefly on portal access, and we can get you up and running on ImageSmart. This is one avenue to access the tool. There's 2 other avenues, in fact, and they are on an iPhone or on your iPad. Those are both available now in the App Store on iTunes.
You can go ahead and download those for free. And then you can contact our help desk to help you log in. You'll need your portal ID, and then we have a specific organization code for security reasons to help you log in. It looks very similar to what's on the web version, but it is definitely more accessible, especially if you're in an EMR or an EHR to access it while it's on your phone or an iPad.
So this is Kim Coleman. So Lori, talk just a little bit about, this is based on the American College of Radiology guidelines, and we have a high-tech steering committee.
Mm-hmm. Yep, we have a high-tech steering committee that has been tasked with improvements to the overall scores for United Physicians when they are ordering high-tech imaging, or any imaging for that matter. This one tool came out of that high-tech steering committee when they discovered this grant that was that has been worked on with Altarum, and it has incorporated the American College of Radiology guidelines to really help with the appropriateness of the imaging orders that are being done. This does not really look back at what has been ordered in the past for the patient, but really how the patient is presenting at the time, and whether or not it would be appropriate to order that test. As you can see from the example that I did, you can use this also as a dissuasion instead of the patient coming in saying, I really need an MRI, I need to know what I did to my back. It really hurts today because I did it 2 days ago. This is really a great tool to help that physician have that conversation with the patient and make the decision together that at this point no imaging is really necessary, and that some watchful waiting is definitely called for.
Great, thanks. So, and I know Dr. Mesla is on that committee and a number of our other providers. So we have a multidisciplinary group of physicians looking at this from their various specialty areas. Ultimately, the goal with this, so one of the, some of the feedback is, well, I'm already dealing with registry and looking for gaps in care, and this is one more step in the whole process. I think, like Lori showed you, it's relatively quick. There are different ways that you can work this into your workflow. Some of the feedback that we've had is that when you are going to go ahead and order a test, if you run it through here and you give this to the person in your practice who is requesting prior auth, it cuts the time down dramatically so that they've got the clinical information that is needed right in front of them. Ultimately, if we can get enough usage of this and demonstrate that it does improve appropriateness, the plan would be to be able to eliminate that prior authorization step altogether. So anyway, thank you for sharing that. So I think we could go back to the main slide presentation, Mike. And at this point, open for questions. Hopefully that gave you an overview of, so the trend reports really are kind of high level. In and of themselves, they aren't actionable down to the patient level, but they do help point you in the direction that you might want to focus if you want to, improve kind of the way the plans are seeing you, or how you look at the plan. So.
Super, Beth.